so that you can get a good idea of what might come up in the Viva part of the exam. Before I start, I just want to tell you that we have launched the autumn 2025 power course. And if you click on the link I've posted in the chat, or go on the QR code, there are a couple of places left for the £50 off. And then it goes up to £299. So do try and sign up as soon as you can. Okay, what is going on here? Got calcified aortic wall, probably a graft inside the aortic wall, and then we've got thickening of the descending colon and sigmoid colon. So put it all together, yeah, ischemic bowel to ischemic colitis, and it's very likely that the inferior mesenteric artery has been involved in this atheromatous process. Okay, neck surgery, expanded ribs, lucent lesion in the humeral head, small cortices involving both kidneys with calcification, expanded rib, expansion of the pelvic bones, and a renal transplant in the right islet fossa. So this is hyperparathyroidism with multiple brain tumors in a patient who's got renal failure and a renal transplant. Okay, what is the diagnosis on this X-ray? It's not a dislocation. There is a lucent lump in the region of the muscle, displacing muscle. Yeah, it's a lipoma. And the best way to investigate the lipoma is to do an MRI scan. And that shows a very well-defined lipoma. Now, if you get full fat suppression, the chances are that that's benign. But the larger the lipoma becomes, or the more heterogeneous it becomes, the more likely you are to worry about potential liposarcoma. So just bear that in mind. More lipomas. Here is a lipoma of the colon, which has resulted in an intussusception. Okay, so lipoma of the colon resulting in intussusception. Here is a fracture of the surgical neck of the humerus in a patient who also happens to have a lipoma. And this is what it looks like on ultrasound. So this is a lipoma. You get lots of acoustic shadowing because of the high reflectivity inside the lipoma. Sunset on the Wirral last year. Hang glider, wind farm, Hilbury Island, beautiful. Okay, this is a highly trained athlete with an injury to the foot playing football. The DP view shows no abnormality, but when you do the weight bearing view, you can see that there's a step between the medial aspect of the second metatarsal and the intermediate cuneiform. This is a Lisfranc injury. Absolutely. Okay, this patient has got an NG tube in situ. They've got a right internal jugular line. They've got a lucency adjacent to the heart. The pericardial fat here appears very sharp. It's resembling a tag. And we've got a deep costophrenic sulcus. We've got a fractured rib. And so this is a supine film with contusion, fracture, and a pneumothorax. Spot diagnosis. Rickets. Yeah, well done. Rickets. Let me just go through that. So we've got cupping of the metaphyses, widened growth plates, very marked soft tissue swelling of the wrists, and we've also got periosteal reactions involving the phalanges and sorry, the metacarpals. Okay, this patient is complaining of cough and weight loss. Any thoughts? Lung cancer. Yeah, we've got lung cancer. We've got some consolidation. We've got paratracheal lymphadenopathy. What about the proximal humerus on the left? Yeah, there's a tumor in the proximal left humerus. It's already been pinned, so there's a plate which you can't see, but there is a metastasis there. Diagnosis? Non-ossifying fibroma or fibrous cortical defect. Either of those descriptions would be adequate. Sudden onset of breathlessness. Yeah, bat wing pulmonary edema. There's a right-sided permanent pacemaker with its tip in the right ventricle. And there's bat wing pulmonary alveolar pulmonary edema. And that's after treatment. Okay, what do you think this device is? You might get asked in the exam. Yeah, ductus closure. Well done. Yeah. So it's a patent ductus arteriosus, which has been detected during adult life, and the patient has just had a ductus closure device. Diagnosis? Left lower lobe collapse. Yeah. Multiple nodules, ill-defined, which are equally spaced out. They spur the extreme periphery. They spur the fissures. These are central lobular nodules. And this patient has also got an area of secondary pulmonary lobular air trapping. And this is a case of hypersensitivity pneumonitis. Could it be miliary TB? Well, it could, but more likely is that this is due to hypersensitivity pneumonitis because of the air trapping. How would you describe the course of this right internal jugular line? Left-sided SVC, and there's another line which is also heading off into that direction. So is this a solitary or a double SVC? Is it a duplicated SVC or is it a solitary left-sided SVC? It's a solitary one because if this was a double SVC, the right internal jugular line would preferentially go down into the right-sided SVC. Spot diagnosis? Scleroderma lung with a dilated esophagus and non-specific interstitial pneumonitis. Skiing injury. So we've got a second fracture and we've got a lipohemorrhosis. So the second fracture is almost always associated with an ACL rupture. But if the ACL isn't ruptured, you will get a fracture of the femoral condyle. And this patient has got a femoral condyle fracture, we can just see here, and that releases bone marrow into the joint, hence the lipohemorrhosis. This is another second fracture, but there's no lipohemorrhosis, there's no other fracture, and that's because the patient has got a rupture of the ACL. So they've got an effusion, but no lipohemorrhosis because no other bones are broken and the ACL is ruptured. Patient's got a cough and weight loss. Left upper lobe collapse. Anything else? There's a hilar mass lesion probably. And there's a destroyed left sixth rib. And we've got a soft tissue mass with destruction of the left sixth rib. And this is a left upper lobe collapse, hilar mass lesion, and we've also got this incomplete border sign. Now you can see that the CP angle on the right is here and the CP angle on the left is here, which indicates volume loss. Okay, so left upper lobe collapse. Always look for the associated metastases. On the lateral view, you can see that the mass lesion is involving the rib posteriorly and it's causing an increased density over the thoracic spine. And then here is the left upper lobe collapse. It's kind of wedge shaped. So there's the thick end of the wedge, there's the thin end of the wedge. And so at the top of the collapse, it's going to appear denser. And at the bottom of the collapse, it's going to appear less dense. Okay. And the reason for that is that you've lost volume, you've got the increased density as the X-ray beam goes through the left upper lobe collapse. So at the top, the left upper lobe collapse is going to be like that. And so you've got the X-ray beam going through here, and then on the lateral, you're more likely to see the interface because this is going to be tangential to the beam. The destruction of the rib overlies the thoracic spine, and this causes an increased density. The more I practice, the luckier I get. That's so true in radiology. Okay, what is going on here on this chest X-ray? So we've got the posterior mediastinal mass. There's the right heart border. You can see the hilar vessels So the hilum overlay sign is present. I can see the right heart border, therefore it's not middle, it's not anterior, therefore it must be posterior. The lateral confirms that and shows a nice demonstration of a posterior mediastinal mass lesion. And this patient is a patient who's got a schwannoma. Here is the obtuse angle that the mediastinal mass forms with the chest wall. And here is the posterior mediastinal mass. There's the posterior mediastinal mass. That was a schwannoma. Okay, what's the diagnosis here? Yeah, this is a right lower lobe collapse because the CP angle is here and the CP angle is probably down here. And so we've got volume loss. You can see a bit of mediastinal shift over to the right. The interlobar artery is now engulfed in this right lower lobe collapse. So there's the right heart border, and there's the right lower lobe collapse, which contains the interlobar artery. The other thing to note is that the right hilum has been pulled down a little bit. So it's a right lower lobe collapse. Patient's got pericardial effusion, and they've got a golden S sign signifying that this is almost certainly due to a malignant tumor. Okay, abdominal film, what's the diagnosis here? Splenomegaly, well done. Big spleen. And it's massive splenomegaly. So this is likely to be a patient who's got myelofibrosis, chronic myeloid leukemia. Okay. Now in the world, it's probably Kala-Azar and malaria, but in the UK, it's CML and myelofibrosis being most likely. You don't necessarily have to have dense bones for it to be myelofibrosis. Okay, what have we got here? We've got a patient with a cough, got lymphadenopathy, and a focus of consolidation. Focus of consolidation with lymphadenopathy. This is primary pulmonary tuberculosis. So primary pulmonary TB tends to give you consolidation and lymphadenopathy. Okay. What is the diagnosis here? Yeah, osteochondroma. Osteochondroma. And you want the cartilage cap to be less than 1.5 centimeters. But the most important thing you can do in somebody who's got an osteochondroma is to look at previous films, because the previous films gives you a story that may not be present um, on the request form. Yeah. So ideally, you would want to know from the request form what's going on in terms of the patient's symptom change. But in the absence of that, you can look at previous films and see if there's any wild change since the previous X-ray. Okay, we've got volume loss in the right hemithorax, got volume loss in the left hemithorax. The hilum has gone up on the right and on the left, and we've got this cicatrizing fibrotic change. This is absolutely sarcoidosis. The progressive massive fibrosis in this patient is central, hence you get the bronchogram, and you can see all this cicatrizing uh, fibrosis, which leads to bronchiectasis. Sarcoidosis. Bone in bone. Why not silicosis? Okay, I'm glad somebody's asked that question. If it's silicosis, the PMF starts peripherally and works its way centrally. Okay. But in sarcoidosis, the PMF starts centrally and works its way peripherally. And that's why you're more likely to get an bronchogram with sarcoidosis than in silicosis. Bone within a bone, osteopetrosis, well done. Okay, this patient's got back pain. Yeah, we've got a lytic pedicle. Well done. So the pedicle here is lytic, and that means that we've got a metastatic malignancy, breast, bronchus, thyroid, kidney. So whenever you see a metastasis knocking off the pedicle, think about breast, bronchus, thyroid, or kidney. Also think about myeloma, and always think about lymphoma in the absence of any other cause. Okay. So this patient has actually got a metastatic renal carcinoma. Delayed CT, portal venous phase with delay. Yeah, giant hemangioma. Well done. The real investigation you need to do in these situations is to do an MRI scan, and you can see that the nodular filling is very nicely demonstrated. There's a central area of high signal on the heavily T2 weighted image, and you've got uh, gadolinium enhancement in a nodular peripheral format. Okay, what have we got here? Bone scan and an X-ray. Yeah, Paget's disease. So the contiguous cortical thickening and trabecular coarsening is seen right from the subarticular region into the diaphysis, and this is mirrored on the isotope bone scan. Okay, so it's absolutely characteristic of Paget's disease. Patient's got knee pain. What do you think might be going on here? Not a GCT? Could be a GCT, but it isn't in this case. Cortex is completely destroyed and it's rather permeative all over. It's just a metastasis from an adenocarcinoma. Okay, it could be a GCT, it could be myeloma. This was actually a metastasis. Okay, but all the things that you've said are sensible. Somebody's mentioned osteomyelitis. That's also a possibility. Yeah, in the differential diagnosis. This patient's got cough and weight loss. Would you be happy to accept that film for reporting? What would you do next? Would you repeat the film? Yeah, of course you would. There you go. And if you remove the patient's hand, they've got a lung cancer in the right lower zone. Now, this patient has got a well-defined lytic lesion in the proximal femur. They then go on to have an intramedullary nail put in. Now, the intramedullary nail is responsible for all of this uptake here, but there's no increased uptake around the lucency. So what's the diagnosis? It's myeloma. Yeah, it's myeloma. What's the diagnosis here? Yeah, old Perthes disease of the right hip. Or if you said old AVN, that would also be acceptable, except we've got shortening of the femoral neck also. This was actually old Perthes disease. This patient presented with a stroke. I think this is really difficult, actually. It's a left ventricular aneurysm. You can just see some calcification here. Better seen on this CT scan, left ventricular aneurysm. And that patient had a stroke from some thrombus that was lying within the aneurysm. Okay, what's the diagnosis here? Yeah, we've got a right-sided mastectomy or lumpectomy. There is still some breast tissue there, but it's significantly smaller than the breast on the other side. And these are multiple metastases. There's also a right pleural effusion and a left pleural effusion. Can't see any bone lesions on this particular chest X-ray. What's the diagnosis in this trauma patient? So there's a perilunate dislocation if the capitate goes here and the lunate stays where it is. Okay, so that would be a perilunate. Okay, so the capitate moves posteriorly and the lunate stays where it is. Now it's not that because the lunate has flipped forwards like this. And so this is a lunate dislocation. It's a lunate dislocation. So check the position of the lunate and check the position of the capitate. The capitate would be articulating with the lunate if it was in the right position. Therefore, it's a lunate dislocation. Diagnosis. So we've got emphysema, carcinoma, and lymphangitis carcinomatosis. Lymphangitis carcinomatosa or lymphangitic carcinomatosis. Yeah, lymphangitis. There's central lobular and paraseptal emphysema because the patient smokes. There's a mass lesion with spiculation because the patient smokes, and there's lymphangitis because the patient has got either a central lymph node obstruction, which is obstructing the lymph return to the thoracic duct, or there is infiltration locally into the lymph nodes, into the lymph channels. Sorry. Okay, this is an infant. This is the thymus. Clavicles have gone. Yeah. Cleidocranial dysostosis. No clavicles. The patient's got a persistent anterior fontanelle and multiple Wormian bones. And when they mature, they'll probably get supernumerary teeth. Okay, I took this from the New England Journal of Medicine, and I will credit Dr. Evan Stein for this. It was in the, oh, sorry, not the New England Journal of Medicine. This was Radiopedia, I beg your pardon. Dr. Evan Stein, and it's a feline esophagus. Yep, and they call it a feline esophagus because in cats, the folds are transverse. And this reflects eosinophilic esophagitis. Now, eosinophilic esophagitis is very rarely just on its own. It's actually a part of a hypereosinophilic syndrome. And there's a spectrum of involvement. So the patient may have GI involvement, they may have pulmonary involvement, they can have liver and cardiac involvement. But this is a patient who's got eosinophilic esophagitis. Okay, young lady with weight loss and sweating. Lymphoma, yeah. So we've got an anterior mediastinal mass, a middle mediastinal mass. We've got a mass in the right supraclavicular fossa and a mass in the right axilla. So these are all lymph nodes, and this patient has got lymphoma. Multiple enchondromas at the costochondral junctions, popcorn calcification. There's an enchondroma involving a flat bone, which is the scapula, and multiple enchondromas involving the phalanges and metacarpals and distal radius and ulna. But the hemangiomas, which have calcified the phleboliths, so-called, um, represent that this is Maffucci syndrome. And Maffucci syndrome is Olliers syndrome with lots of hemangiomas, and this carries a slightly worse prognosis because there's a higher incidence of malignant transformation into chondrosarcoma. Okay, so Maffucci's, which is spelled Maffucc, so two F's and two C's, is essentially Olliers disease with hemangiomas which calcify and become phleboliths. This is the same patient a few years later, and they've developed a chondrosarcoma of one of the ribs. Malrotation. Okay, there's the pylorus, and the DJ junctions should be at the same level over here. Okay, so what happens is the D is here and the J is here, and it should be at the same level as the transpyloric plane, but clearly it's all over onto the right-hand side due to malrotation. Okay, patient's got hip pain. Any thoughts? Yeah, we've got a lytic lesion in the proximal right femur, which is destroying the cortex, and this is permeative in appearance. This actually turned out to be a lytic metastasis. I can't remember now, but think about bronchus, um, renal, thyroid, and in a female, it would be breast. Okay, what have we got here? Right mastectomy and sclerosis of the rib. So this is a sclerotic metastasis from a patient who's had a mastectomy. Okay, what have we got here? Yeah, osteoporosis circumscripta. So we've got a very well-defined lucency involving one of the parietal bones and frontal bones. Sorry, both frontal bones, one of the parietal bones, and then the occipital bone, and the rest of the parietal bone is uninvolved. That's where you've got three different levels. There's another case and another case, and this is what it looks like on a bone scan. Osteoporosis circumscripta. Okay, so what have we got here? Meckel's diverticulum. Yeah, well done. Meckel's diverticulum. Patient has had an emergency tracheostomy. They've had this put in, and then they've got surgical emphysema. And then the next day, they've got an air fluid level in the mediastinum. So what's happened? They've got mediastinal abscess. Yeah, well done. Okay, what have we got here? Yeah, this is a peritoneal mesothelioma. So if you saw this in the thorax, you would call it a mesothelioma. And that's exactly what you've got. Okay. Big spleen, dense bones. Yeah, myelofibrosis. Well done. So we've got a very marked enlargement of the spleen. And so this patient has got dense bones and splenomegaly, myelofibrosis. This patient's febrile with breathlessness. Miliary TB, well done. And after treatment, patient has got a normal chest X-ray. What's the diagnosis here in this newborn infant? Duodenal atresia. Yeah, well done. Now, I've just noticed that all our coupon codes have been used up. So I've placed another coupon um, link, and this will add another 10 coupons for £50 off. Okay. So if you go into that link, you'll get £50 off um, the price of the course, which is going to be done in autumn. Okay. So go into that link. Okay, what have we got here? Yeah, we've got an enlarged left atrium. We've got mitral valve replacement. We've had a CABG graft, enlarged hearts. This is mixed mitral valve disease. Mixed mitral valve disease. Another case of mixed mitral valve disease, splaying of the carina, double right heart border, pleural effusion, and mitralization of the left heart border. What's the diagnosis here? This is multiple sclerosis. Multiple sclerosis. Very large lytic lesion, which is cold on the bone scan, and all the increased uptake is due to microfractures, also due to whatever's going on. Yeah, this is myeloma. Well done. Can you see the aortic knuckle? Yes. Is this separate from the aortic knuckle? Yes. That's because it's a posterior mediastinal mass lesion, and this patient has got a posterior mediastinal mass, which is a schwannoma. There's another schwannoma. Can you see the hilum? Yes. Can you see the right heart border? Yes. Therefore, this is a posterior mass lesion. There it is, and it turned out to be a schwannoma. Okay, I'm going to finish there, but I've posted that coupon code again exclusively for you tonight, not for anyone else. Those who've attended this Zoom, and you can get £50 off if you click on that. We're going to do a power course in January. We're going to do